Good morning. Good morning, everyone. Welcome to the third and final day of the Ogden Surgical Medical Society annual 66th annual medical conference. 66 years is a long time. We are, I mentioned yesterday, the longest running annual conference in the Western United States. I hope everyone's enjoyed themselves on the past 2 days. I think we have an exciting lineup of speakers and breakout sessions today as well. Just a few organizational notes. If you could again please just mute or turn your cell phones and pagers to vibrate so that it doesn't disrupt the speaker. And just another reminder, if you've signed up for the golf tournament, don't forget it's tonight at the Ogden Country Club. If you'd like to play golf tonight, see someone at the registration desk and we'll give you all the information you need. I'd first like to introduce Dave Allen, who is going to be the president next year as of tomorrow. And he's going to introduce our first speaker. Thank you.
Good morning. I offered to have Heather go ahead and do this next year because she did such a fine job this year, and she politely declined. It's my pleasure to introduce to you this morning Eric Holley, Dr. Eric Holley. Dr. Holley was raised in Salt Lake City and graduated from the University of Utah with a degree in exercise physiology. He then went on to Milwaukee, where he received his medical doctorate from the Medical College of Wisconsin. He stayed there at the Medical College of Wisconsin to complete an anesthesiology residency, and then from there went on to Stanford University to do a pediatric fellowship at Lucille Parkland's Hospital. Following that, he returned back to Salt Lake City, back to his roots, where he now practices at Primary Children's Medical Center, and he currently is teaching his wife's son book and one of his two daughters both how to ski. So keep that up, Eric. Eric's going to talk to us this morning about some pediatric dermatology or pediatric anesthesiology issues, and we'll go ahead and turn the time over to Eric.
Thank you, David. Teaching a 5-year-old to ski, I'm sure many of you have done it before. It's a great experience. Season's over, but she learned a lot. I'm going to talk a little bit about something that's kind of become a topic in the pediatric anesthesia world, and it will likely become a topic for many of you because the drugs that we're talking about in terms of how they affect kids, not just acutely through the procedure, but the question really is what's going to happen to a kid who has an anesthetic and you look at them, 18 years later, are they less likely to graduate at the top of their class than the other kids? So we've got a little bit of research to guide us, and we'll talk about the future direction where that's going. But these are all drugs that many of us use or at least receive on the other end. This is midazolam and propofol and opioids. So we think anesthesia is safe. We get kids through difficult or painful procedures. They wake up at the end. They start doing everything afterwards that they were doing before, and we pat ourselves on the back, and we're good. But there is some data out there that says, at least in some animal studies, maybe a successful anesthetic is not as successful as we thought it was. And there are certainly reports from parents about kids who had a procedure, they had hip surgery done, and it is now 5 months later, and they're not sleeping well, and they have behavioral problems. And the question is, what caused that? Was it the anesthetic? Was it the stress of being in the hospital? Was there some sort of inflammatory thing going on? So people have looked at this a bit. In the 1950s was kind of this more acute stuff saying, kids sometimes at the end of this anesthetic, they tend to be pretty upset and angry and belligerent. I don't give a whole lot of credence to that. that is an acute thing, and most kids, we've actually gotten pretty good at helping the kids through that little portion of things here. 1970s, along with the fetal alcohol syndrome things, they said, well, let's not look just at alcohol, let's look at some of these other drugs. This is more in utero exposure. And then in the last decade is really when we've started to see a lot of the research centers trying to figure out what this means to our kids. How do anesthetics work? We're going to talk about the top two today, GABA and NMDA effects. Opioids and the alpha-2 agonists like dexmedetomidine have, if you look at the research that's out there, it's more scant for those, but it's really not all that different, meaning that we've got some studies out there that show that, maybe there's a problem, and some studies out there that refute that. So certainly more to do, but we have more information on GABA and NMDA, so we'll talk about those today. So these are drugs that are familiar. You know, if you're getting chloral hydrate or Versed or anything like that for a procedure, that's what these kids are using. And ketamine, at least, is popular in our ER at Primary Children's. I'm not sure what we're using elsewhere. So a brief review of GABA, stuff that I've learned and forgotten and relearned and forgotten and relearned. And so GABA is the inhibitory signaling process that we use in our nerves. And so this is the thing that when GABA binds, it calms everything down. Chloride flows into the cell. It makes things more negative. It's less likely to fire. Interestingly, and we really don't know what this means for anesthesia, but it seems that in the early stages of development, it actually serves an excitatory potential. The drugs still work on the kids, so I'm not sure what exactly that means to us. But it's also really important in this synaptogenesis and this pruning that goes on as well. Remember, is that we start off with a bunch of neurons in our brain and a bunch of synapses going a bunch of places, and part of the development that we go through is to get rid of the synapses in the cells that aren't serving us well and strengthening the connections that are important. And GABA plays a role in terms of that. And it's not quite sure if the problem with these drugs is that is the increase in activation of this receptor causing the problem, or is it that the increased activation causes an atrophy and it's the subsequent withdrawal of it? Nobody's quite sure, which is the truth also for NMDA. We don't know if it's the trophic or whatever that's causing the problem potentially. But once again, it's important in this pruning process that happens within all of our brains as we were developing. Glutamate's the other end of the whole thing. It's the predominant excitatory thing. Goes through and it makes things more towards the positive end, and so the nerve's more likely to fire. This is where ketamine and nitrous oxide tend to work. So when you give a kid a GABA agonist, propofol, all of the inhaled anesthetics, the benzodiazepines, barbiturates, what is the long-term result of that? Or so in 2002, they looked at this and they said, well, if you give a 7-day-old rat, and they choose 7 days because that's when most of this is happening in a rat, most of this neuronal pruning is happening in a rat, and say, well, let's take a rat and put it in a little box, actually a bunch of rats, and for 6 hours we're going to give it some isoflurane, some nitrous oxide, and a varying amount of midazolam. And then afterwards, we're going to wait a month, we're going to let them go back and feed and do whatever they do, and then after a month we're going to cut up their brains and put them on a slide and see what the difference is from our controls that we simply put in another box and didn't do anything for them. And what it showed was there's brain changes from the controls. And also, if you take these 1-month-old rats now and you put them into a water maze or some sort of other learning thing where they have to learn where their food is and then go find it and repeat the process again, The rats that were in the study group don't do so hot. Now, it is interesting to note two things on this. One is the doses of some of these things. Midazolam, 3 milligrams to 9 milligrams per kilogram. This is not 3 milligrams of midazolam. This is 3 per kilo. This is like taking your 10-kilo 2-year-old and giving them 30 milligrams to 90 milligrams of midazolam versus a typical dose that I give a kid who's got an IV who's coming back to the operating room. I'll give that kid 2 milligrams. 30 milligrams would be excessive. But it seemed like if you used just midazolam or just nitrous oxide, you didn't have this problem. If you look at the other receptor, NMDA, in 2002 also, they said, well, let's take these 7-day-old rats, these poor 7-day-old rats, and we'll give them 25 milligrams per kilogram of ketamine. We're going to do that every 90 minutes for 9 hours. And then 24 hours later, we're going to look at their brains under a microscope and see what happened. And it turns out that those rats had significant degeneration shown on the slides. Now, the ones that you gave just a single dose of, even 75 milligrams per kilogram, 24 hours later didn't show any problem. Once again, for a little bit of perspective, an induction dose to induce general anesthesia in a human is 1 to 2 milligrams per kilogram. So we are way higher than this with these things. But the single dose seemed to not be a problem. Fredrickson, a couple years later, said, well, he looked at it in 10-day-old rats. I don't know why they chose that. But found out that, 2 months later, there was some learning problems if you tried to put them through the maze. Okay? They're two different studies. One's just looking under the microscope, and one's looking at actual behavioral abilities later on. So we've got something that says, well, don't use barbiturates because, or don't use GABA things like barbiturates because they're going to cause problems. And now we say, well, don't use NMDA because that could cause a problem. But what do we do with this information? To start with, I think the doses, are the big elephant in the room, and they are big. The doses for most of the studies that I look at, the ketamine is 10 to 40 times what would typically be used in a clinical pediatric anesthetic setting, and certainly true for most of the sedations that I think that we see in the ER and radiology and elsewhere. Propofol, midazolam, similar dose discrepancies from clinical practice. The other important thing to note is they just take these rats and they just throw them in a box and they give them all of the drugs that it's included in the study group. Nobody's checking their blood pressure or checking to see if their lips are blue. Nobody is trying to monitor their movements. Nobody's checking heart rate. There's no pulse oximeter. And so we're just kind of seeing what happens after this rather enormous exposure. And Stratman also noted that about 20% of these rats die as a result of these studies. And so actually when you consider a 20% mortality, not being able to find the food as fast as the other one may not be all that bad of an outcome. But that's the data we've got. The other thing is, we don't take neonates or pediatric patients and just give them these drugs and put them to sleep just for our own pleasure. There's usually something else that has to happen. That's why we're doing it. And usually that thing is quite stimulating. And so there's two things there. One is we do have studies that show that doing something that is quite painful and stimulating has bad effects on the brain. And we have studies that show that if you compare a group that actually gets some analgesia prior to that, their brains look better afterwards. This is animal research. So there's some therapeutic stuff there. And also, the doses that I've been talking about that I typically give these kids, you give these doses in the face of rather stimulating things that are happening. If I gave a surgical dose of a medication, and then the surgeon is busy elsewhere, then I'm probably going to be supporting that patient's blood pressure for a while until the surgeon comes in and starts inflicting some pain to bring it up for me. And then there's the question of the window of susceptibility. When are these kids at risk for this? It seems like we've identified in rats that about day 7, day 10 is when they are most likely to be susceptible to damage from these medications. But what is the analogous time period in a human child? We'll look at that. So historically, classically, we've used 0 to 3 years, and that's just based on developmental observations of how much myelination, the numbers of cells and everything in the human brain. But better data seems to indicate, and if you look at this, there's this great website, translatingtime.net, which is something that broke off from these people who are a lot smarter than me, trying to figure out in different species when are these analogous things? Because obviously, for different organ systems, there's going to be different time periods that are similar. But at least for the brain, they've kind of figured out that if you're doing rats, and it's actually a very simple tool. You plug in what age you're interested in human, and you tell them what other species you're going to be studying, and they'll give you the time that, at least based on our current data, seems to be most analogous to that. And so it looks like we're looking more like 20th week gestation to the early newborn period is what we're looking at. So your 2-year-old, your 18-month-old, even your 1-year-old, probably, we think, not so much of a concern. But the jury's still out on that. But let's look at what we do have, because we do have some human stuff out there. Nobody's been able to take a bunch of human babies and put them in a box with a bunch of midazolam past the IRB yet. But people have done retrospective stuff to say, well, what about if, let's look at kids who we know have had surgery and compare them to kids who didn't have surgery and see what their outcome was a few years later. And so in Rochester, there's apparently a community hospital and the Mayo Clinic. And so these researchers kind of came up with the idea that said, well, let's just assume that every kid that was born in this county, if they had surgery, most likely it got done either at this community hospital or at the Mayo Clinic. So they took the birth records from the county. They took the hospital records from this community hospital in Mayo and identified kids who'd had surgery. And then they took school records with an agreement that they have with the school district that covers that county, and they identified kids who were learning disabled. And they used the definition of learning disabled as 1.75 standard deviations lower than the mean. And we're going to identify you as learning disabled. And this is what they came up with, is the lowest line there is kids who were not exposed to any anesthetic. The next line up is kids who had a single anesthetic exposure prior to age 3. And then the next line up is people who had multiple anesthetic exposures prior to age 3. Multiple meaning 2 or more. And there really wasn't a difference between kids who just had one thing happen and kids who had multiple surgeries. So that gives you reason for pause. Now the question, though, is what kind of kids have multiple anesthetics prior to age 3? I mean, there's a difference between a kid who, has a little bit of, maybe has a polydactyly or something like that, and you're going to, take off a little skin tag that kind of looks like a finger, and a kid who has congenital heart disease and has hydrocephalus and everything else that needs to be shunted. And so that's the data, but the value of that human stuff is a bit questionable. So in New York, they said, well, let's take all the kids in New York on the Medicaid thing. And this is purely from billing data, so it's a bit questionable. But they said, well, let's take anybody who has, we're trying to separate out people with major congenital problems from kids who just needed a little surgery with anesthetics. So we just looked at kids in Medicaid who had the CPT code for an inguinal hernia repair prior to age 3. And then they took 5,000 age-matched kids from that same Medicaid database, controlled for age, gender, birth weight, and then looked, and they found that the kids who had something done prior to age 3 were almost 2.5 times more likely to also now have a diagnosis code later on for some sort of developmental or behavioral disorder. So, what we haven't figured out with any of this stuff is this an anesthetic effect causing these things? Or is this something else? Is it that, I think the most likely problem would be, is this the fact that kids who need to have multiple procedures are not the same as kids who don't need to have multiple procedures? Or is there some socioeconomic stuff going on here? There's no end to what you could possibly be looking at as in these just kind of retrospective pulling the billing data out. It just doesn't control for things. So when we have confounders, we always turn to Northern Europe to help us out, because they have these patient registry databases, and they have all sorts of stuff that you can look back on and try and figure some stuff out. So this Netherlands twin study, I think, is an interesting one. So this is in 2009, and there's this registry that has all these twins in the Netherlands. And so they identified in this database monozygotic twins where one of the twins had had an anesthetic prior to age 3. And they said, we know that low birth weight and prematurity are associated with learning difficulties later on. So let's just get rid of the obvious problems so that that's not messing up our data. And they identified 1,100 kids, 1,100 families where one of these kids have had some surgery. There's a test that everybody in the Netherlands gets in 6th grade, and so they had access to that. And they found that sure enough, if you had an anesthetic exposure prior to age 3, then you had a lower test score than the matched population kids. But the interesting thing is this is a twin thing. So we had a sibling that would have had similar socioeconomic things going on and probably similar schools and everything else. And they found that while they were lower than that, they were not lower than their non-anesthetized sibling. And then one more study from Denmark. This is hot off the presses in the most recent issue of Anesthesiology. Once again, we turn to Northern Europe for information. They found kids who'd had, they took it down from 3 years down to 1 year. So we identified kids who'd had an inguinal hernia repair, which we think is not associated with a lot of other anomalies. And they found 2,600 kids that they matched them to 14,000 other kids born between 86 and 1990. And the nice thing about this is they don't have nearly they're a lot more homogeneous than we are in terms of geography, in terms of socioeconomics, in terms of ethnicity. And they have access, everybody has access to health care, so you kind of remove that confounder. It's a simple, common thing that a lot of kids have done, and they didn't have anesthetic data. They don't know exactly what anesthetic each one of these kids would have had, but based on the interviews they'd done with people who worked during this time period, it was pretty much some midazolam and either isoflurane or halothane. And so they think that it's roughly a common anesthetic among all these kids. And the sample size is huge. They had 4 of these databases, the Danish demographic database, the Danish National Hospital Register, where they identified the kids. The labor data to find out kids' socioeconomic and education things, and then their school scores. Turns out that, and they have this test that's given to just about everybody. If you don't get the test done, only 87% took it, it's usually because you're falling way below. These are kids who are on alternative educational paths. As shown by the fact that if you had neurosurgery at age less than 1 year, you had a 50% chance that you didn't ever take this test. So those were all thrown out, okay? And the raw results are that, you were about 5% of a standard deviation than your matched peers if you'd had an anesthetic prior to H1. And these kids were thrown out. They had a 1.18 higher risk of not even taking the test. So that's the raw results. Now, they looked at the confounders that you had in there. There are way more males in the study group than in the anesthetized group than in the controls. Their birth weight was lower, and age and education were slightly lower for the anesthetized population, although there was a significantly higher other congenital malformations noted on there. And so when they looked at the whole thing, they said, there's about this 5% of a standard deviation drop, but that was way smaller than all of the other things that we looked at. You were much more likely to be affected by your parents' education level and your birth weight than you were by any sort of anesthetic exposure. And then, so now that we've said, well, there may be a problem, it's important to say you have to anesthetize kids. If you have to do something, you have to anesthetize them. They've taken these rats and they say, well, what if we inject painful formalin into your tail versus what if we do formalin and ketamine or just ketamine? And it turns out that the people the rats that did poorly were the ones that just got the pain and without anything to deal with it. There's also the thought of preconditioning. This is kind of an anesthetic thing, but they found that prior to doing heart surgery, if you give the heart a bit of ischemia prior to a bunch of ischemia, the heart that had a little bit of ischemia first does better. And it turns out that anesthetics do about the same thing. They help avoid that hypoxic damage. So we need more stuff. There's a study going on now. It's going to give us, in about 5 years, we'll get something about kids at age 5 that we're going to randomize to either getting a spinal for inguinal hernia repair or a general anesthetic. That'll give us some data in about 5 years. We'll see how useful that's going to be. I think that we're going to be more interested in the data at 18 years and 22 years. But for the future, if parents ask you about these things, smarttots.org, they're the people who are kind of coordinating all of the various research things that are going to start now. The FDA is very interested in this. It's got a parent portion on it. It's got a for physicians portion on it. Evaluate whether or not this should be done earlier or later. There's a lot of reasons to do things earlier. You get craniosynostosis things. It's certainly a much easier procedure when the kid's small with a thin calvarium than when you do it later. A lot of talk about should we be giving these kids other things that we think may negate the negative effects of these things, and the panel that was concluded a little while ago said absolutely not. We're talking about a possible minimal problem somewhere else, and and you're giving things to counter it that we don't quite know their effects either. The advice for now is to just continue current practice until we find out more. And if you get a chance to be in a study, go for it. Any questions? Yeah.
Are you familiar with the pediatric data regarding perioperative dopamine antagonist and related outcomes in terms of motor
For all questions, can I go to the microphone? We're recording this too, so that we can have it, and then people can hear. I see there's a microphone here and over here too. Teresa, is it on? Maybe you could just repeat his question. Okay. Go ahead and repeat it.
So the question was regarding perioperative dopamine antagonists, correct? And I don't know. Not something that has been looked at, I believe, in the pediatric stuff. And I don't know about the adults. Okay. Any other questions? Yes.
I heard your conclusion that we should just keep doing what we're doing. But we're sending in primary care. We send a lot of infants for semi-elective procedures. The data that you present seems to fly in the face of continuing to do just everything normally for those kind of procedures. Should we be considering waiting until they're all 3 years old to fix the extra finger, the cosmetic things, maybe hernias?
Well, I think that the data would show that 3 years old is probably old school. And I think that, you know, I'm the one who has to take care of them. I would always love them to be older. But I'd say a year is probably a more reasonable thing to say. But that is for things that are truly elective, and, you know, if there's no benefit from doing it earlier. And, you know, benefit sometimes is a bit hard to define. You know, I talk to my urologist colleagues and they're like, well, you know, what if we wait for this thing, you know what? And certainly there's a lot of things that need to be addressed prior to potty training that we may look at and say, well, that's elective. But, you know, potty training is one of those times when kids become even more aware of their genitals, and it's probably good to have things fixed prior to that. You know, craniosynostosis is one of those where it is kind of cosmetic at that point, but it's certainly less blood loss and easier surgery early. So, yeah, I think that the question has to be, and I think the question to ask the surgeon and to ask yourself is, you know, what would happen if we just waited till they were a year? Yes?
So how does this fit in with the postoperative cognitive decline that we see in seniors?
Excellent question.
Recently, they've been shown in mice that if you give the mice Remicade before you operate on them, that they don't get it.
Yeah, I can't claim to be an expert on senior postoperative cognitive dysfunction. This is another one of those areas where there's data that shows problems, but there's also data out there that shows that, we used to associate this postoperative decline with, the anesthetic must have done that. But they've got plenty of studies that show you do a regional anesthetic for the same procedure, and the incidence of the postoperative cognitive dysfunction isn't any different. And so there must be some inflammatory thing going on there. And I've seen the Remicade thing, but because I do pediatrics, I didn't look too closely at it. Okay. Any other questions? Okay. Well, thank you.